I'd like to invite Professor Khan to come to give his talk, if he would, please. Thank you very much. Professor Khan is Professor of Women's Health and Clinical Epidemiology at Barts and the London School of Medicine. He's authored 20 books he's authored over 250 peer-reviewed journal articles and authored 20 books and chapters. He's editor of Evidence-Based Medicine and, do you call it the BJOG? An international journal of obstetrics and gynecology. And he's going to tell us, really, linking back to what I was saying about my brother-in-law and my son-in-law, what EBM has done for the medical field.
Thank you very much for inviting me. Until I arrived here this morning, I knew almost nothing about veterinary medicine. In fact, I did not know there are nearly 18,000 of you around in the UK. And that every day you are treating individuals from a very large range of species. And I only know one species. And in fact, I only know the better half of that species, being a gynecologist. So my job is easier. Your job may be more difficult, but then it must also be more challenging and exciting. So I think it's great that you're all here thinking about this idea. What is this idea? I'm going to talk a little bit about what is involved in the evidence-based medicine journey. And then I'm also going to talk about how to teach this and the lessons we have learned about how to teach this in medicine. It was hinted earlier that there are different names for this idea. I should emphasize that it's well known from research on diffusion of innovations that if an idea has the capacity to develop new versions of itself, it is in fact far more likely to be successful than one that has exclusivity. So don't be worried about what you call EBM. As long as the idea is the same, it's more likely to be successful if different people call it different things and adopt it as their own. Here is a little story about use of steroids in preterm labor. In the 60s and early 70s, we learned that if we were able to give steroids to prematurely born sheep, then they were more likely to avoid the problem of respiratory difficulty after birth. The first randomized control trial in human which showed that this stuff is effective was published very early in the 70s. And then there were several trials along the way. By the mid to late 80s, when we collated all of those trials into a meta-analysis, it was clear beyond any doubt that this intervention is very effective. In fact, by that time we also knew it just did not prevent difficulties in breathing, but it also stopped people from dying. It was not until around 2000 that the Royal College of Obstetricians and Gynecologists included this as a compulsory recommendation in its guidelines. And let's say there was a 10 or 15-year delay in this guideline. Imagine how many babies were born prematurely, spent weeks and months in intensive care unit because of respiratory problems, and how many of them died. It's stories like these, and these stories are common across all different aspects of medicine. It's stories like these that have made us think about why evidence-based medicine is important. And the challenge for us is that The green graph shows us the route we will take to get there if we did not have evidence-based medicine. And the idea with evidence-based medicine is to make that journey quicker and faster. And to make that journey quicker and more efficient, it isn't just about how quickly a librarian can pick up a research article from a journal to give it to you for use in your practice. It is also about how we do studies quickly that generate those articles to come about in the first place. So let's look at what did we do before the so-called evidence-based medicine came about. By the way, the term evidence-based medicine was first published as a, if you like, technical term in a medical journal in the mid-90s. So the concept is old, but the name is not so old. We place, what I'm saying here is generally true also of what we do in our daily lives. We place high value on authority. Children are told to listen to their parents and elders and teachers, and they don't want to be challenged by people younger than them. And the younger ones look to the older ones who they consider as having expertise to sort out problems. But there is no way of checking as to the wisdom handed down to us by the so-called experts has any validity in it. We just accept as part of our daily lives. So in medicine, the old paradigm is that practice is fairly unsystematic. We rely a lot on knowledge of biology and pathophysiology to inform how we practice, and we rely on expertise and authoritarianism. Is it a surprise that the term evidence-based medicine became fashionable and embedded in practice? We've been trying to change societies after the Second World War, isn't it? We are revolting to the idea of tradition. That's how Woodstock came about. And that's, in my opinion, also how evidence-based medicine has come about. It says we are going to be systematic. We are not going to rely on pathophysiology. It is okay, necessary, but not sufficient. And we are going to develop rules of evidence. So we will use these rules even to make judgments about experts as to how expert they are. I will come back to these rules in a second. Is the paradigm in practice changing? We are doing lots of randomized trials and meta-analyses. You are familiar with these terms, randomized control trial and meta-analysis, right? Do you do this in veterinary medicine? Good. Critical appraisal of medical literature. In your exams, do students have to read a paper and say whether it was good, bad, or ugly? It's now become virtually a standard part of medical education, both undergraduate and postgraduate. The medical journals over the last decades have changed from narrative abstracts to writing structured abstracts. And the idea behind that is that we can identify information into a hierarchy according to rules of evidence very quickly without having to read the whole article. Practice guidelines are around. Do you have practice guidelines as well? Yes, for some things? Yeah, okay, good. And continuing medical education, presumably you have something like this too? Yeah? Focuses on knowledge translation and knowledge transfer. So all of these things are indicating that we are moving in a direction that we call evidence-based medicine. This is just an example of a postgraduate training program where trainees are expected to know something about critical appraisal and evaluate multi-center trials. I think you're going to hear about this a lot throughout the day today, so I'm not going to spend a lot of time on what these steps are. But the bottom line is, if you don't know something, you don't just use pathophysiological principles or phone the closest friend or senior, but you try to acquire information about solving that problem, subject to you having time available, appraise that information for its value, and then apply it. This, I think, is not too different from what you do in your practice too. When a problem is presented to you, you can probably have some idea of what the origin of that problem is. Then through taking history, performing examination and tests, you can make a diagnosis. Then you can give a treatment in the hope that your treatment will change the outcome of that problem. Alongside this care protocol, we have different types of research. So etiological research and basic research helps us understand where the problem is coming from. Diagnostic research helps us with diagnosis, and prognostic and therapy research helps us with decisions about treatment. In medicine, somehow there is a belief that randomized controlled trial is the gold standard. Is that the same in your field? Okay. I'll urge you to think about how this diagram is developed. You will very quickly realize that actually randomized controlled trial only applies to therapy. You need other types of research designs for prognosis, diagnosis, and etiology. So if you think about all the different aspects of care that we provide, in fact, only the treatment part is one that relies on randomized controlled trial. We'll come back to that in a second. But here is an example of what we did in traditional practice. Problem, experience, expertise, pathophysiology, decision. EBM encourages us to ask the question, acquire the literature, appraise it, and then inform our decision. So there are lots of other steps involved. This also means that we have got to learn to work with other people, like librarians. We've also got to learn to work with new technologies. Computer is no longer a new technology, but things like handheld devices make the solution, the EBM as a solution to practice easier, because you can acquire and appraise literature more quickly and readily. So this is what I was talking about: randomized controlled trials, observational studies, and uncontrolled studies. As I said, I think we should remove this idea and think about what is the problem and how do we solve that problem. And in order to do that, something new is coming about, which is called GRADE. In the grading system, we have an interest in a number of different things, not just the design of the study. And these things are whether the study has limitations, what the results are, consistent or inconsistent, are the results reliable. And when we consider all of these criteria, we can then come up with a bottom line. So here we have randomized controlled trial where no limitations and no other problems. And as a result of that, this randomized controlled trial can be qualified as high quality evidence. On the other hand, we have another randomized controlled trial, but with some limitations and problems. And here, given the same study design, we downgrade the evidence to low. Does that make sense? So these are things that are changing in evidence-based medicine. Just to show you an example, randomized trial is not the only thing that should guide policy and practice. If we relied on randomized controlled trial to make policy about smoking, we will never be able to do that because we cannot randomize people to smoke or not smoke. So in my opinion, evidence-based medicine is the most ethical way to practice. It incorporates expertise with evidence, and it values expertise particularly where evidence lacks. It helps us to identify what we don't know as a means to initiate learning, and this is the most successful way of learning. It helps with knowledge translation, and with this background we'll move on to how I think we should be teaching evidence-based medicine. The tradition is that we teach almost everything in lectures and expect for it to be translated in practice on day one. This obviously only ensures that the teacher has covered the subject and does nothing to ensure that the student has learned something. So we got to change that idea. So for evidence-based medicine, it's very important that when knowledge comes out, it does not leak through the pipeline until it gets to where it needs to go. And to do that, we need to identify knowledge, be persuaded by it. Following persuasion, we need to be able to make a decision, implement the decision, and then continue to follow what we agreed to do through decision and implementation. This is not easy to do. Only the first aspect, knowledge and identification of knowledge, has to do with research and library service. And everything else has got to do with working with people. So when we talk about evidence-based medicine changes practice, actually it isn't the evidence that changes practice, it is people who do. So we need to be thinking about how we engage with people in making the whole thing work. So here are the different steps of evidence-based medicine. Asking question to putting those findings in practice on the right-hand, on your right-hand side, and on your left-hand side, something similar but in educational terminology. And it ultimately talks about how education changes delivery of care and people's behavior. And now if we look at teaching courses that exist in evidence-based medicine, we can see that there is a lot of emphasis on asking questions and acquiring literature, but the bars become shorter in their height as soon as we start going towards applying the findings, changing behavior, and changing delivery of care. So this is where the emphasis on teaching needs to be. We did a survey of postgraduate courses run across Europe, and these are the main findings. Actually, EBM is not taught as often as we think it is. It's almost always isolated from practice. It's not directed at improving the application of evidence. It's only directed at learning about where to find evidence and how to appraise it. It does not address barriers to change. It does not address on-the-job training. And people who can provide this training on the job are very few. So we had European Union funding to establish a project around these problems, and we created a couple of courses, one about learning about systematic reviews and the other about teaching the trainers. And the courses are available freely on the web, and especially the one about teaching trainers has the opportunity to show you from videos taken on actual ward rounds as to how people engage with a range of professionals in the healthcare setting to identify evidence and to put it into practice. And this stuff was put into a randomized control trial involving 7 countries and 60 hospitals, and it showed that people who went through this e-learning packages had improved knowledge and skills, and not only that, but their workplace environment also changed in that they felt more confident about being able to challenge authority. So e-learning, in my opinion, is better than lectures for teaching materials related to knowledge and skills in evidence-based medicine. E-learning does not become tired, whereas a teacher can. E-learning can be run at any time of the day or night, whereas teacher is only available at a fixed time. And it is this flexibility to the learner that I think can translate into changes in knowledge and attitude, which we have seen in published studies. E-learning can also facilitate harmonization. So if you are talking about interacting with other veterinary medicine societies across Europe, Strasbourg, then e-learning is far easier to harmonize, because once you have prepared a material, it can easily be translated or dubbed. And teaching teachers to acquire competence in on-the-job training is feasible through e-learning. And it is better than standalone teaching the teachers courses. So I would encourage you to think about developing EBM in at least 2 or 3 different battlefronts. One front is to carry out the research. Another front is to teach the younger generation that this is the appropriate way to proceed. But this cannot happen until you develop a pool of trained teachers. Because the last thing you want is students to be enthusiastic and teachers to be opposed to the idea, or not competent in teaching that idea. So what has evidence-based medicine done for medicine? In my view, it has done 2 main things. It has defined for us what is evidentiary in medicine. So when we have a therapeutic problem, we look for randomized controlled trial. When we have a diagnostic problem, we look for an appropriate diagnostic study. We very seldom look to pathophysiological principles for finding solutions, except in cases where we have rare problems where studies don't exist. And it has provided us a new framework for practice where we need to learn to engage with technology, with research, with other professionals. And this can be best learned through on-the-job training. Thank you.